Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Joan Buckley from the Nursing Department here at Nassau Community College, and today we're going to learn all about hypertension, otherwise known as high blood pressure, and why keeping an eye on this part of your overall health is so important. Our guest today is Dr. Mason Freeman, the Chief Medical Officer of Syncor, a clinical stage biopharmaceutical company with a mission to bring innovation to the pharmaceutical treatment of cardiorenal diseases. He's also been affiliated for over 30 years with Massachusetts General Hospital. So, Dr. Freeman, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
Joan, thank you very much for having me.
Can you tell me, this is what I always ask people, what drove you to your specialty and what drove you to Syncor? Because it's two different parts of you. I mean, you're a physician and you have a specialty with, I'm assuming, cardiac, right? And your focus is on something very specific, and I thought it was very interesting reading about it.
I'm actually trained as an endocrinologist, so an internal medicine physician and an endocrinologist, and my interest in preventive medicine, sometimes called preventive cardiology, because that's the focus of much of preventive medicine, but not all, actually began back in the 1980s when I helped develop one of the first statin. And the goal here was to prevent heart disease. And heart disease that cholesterol-lowering medicines change is focused on atherosclerotic or vascular disease that you get blockages in your arteries. But it turns out that hypertension is another very important contributor to that process. So early on in my career, working on the prevention of heart attacks, I became very interested in hypertension.
What does an endocrinologist, how do you fit in? I mean, I know how it fits in, but I just want to make sure the listening audience knows what you were doing before you all started with this preventive piece.
Well, endocrinology focuses primarily on hormones that affect human body functions and physiology. And so the typical endocrinologist that your audience would probably interact with is the two most common endocrine disorders are a problem with their thyroid gland, either overactive hyperthyroidism or underactive hypothyroidism, or somebody with diabetes. Endocrinologists are the main managers of diabetes once it moves beyond the care of a general practitioner or a primary care physician. So they're usually the ones that prescribe more intensive insulin regimens. But all of those things involve hormones, thyroid hormone, insulin, and in the case of hypertension, there's a hormone called aldosterone that is exceedingly well studied, a lot of it done by people in the endocrine field, which is a major regulator of salt and water retention by the kidney and plays a big role in hypertension. And so that's where endocrinologists fit into the kind of preventive medicine, preventive cardiology division. There's actually a part of the American Heart Association that's been called for a long time the Cardiovascular Endocrinology Division. And so we have this little cadre of endocrinologists who focus, it's not quite so little actually, but compared to all the cardiologists at the cardiology meetings, we're a little bit of an offshoot and somewhat odd ducks because we're not cardiologists, but we really care about the things that cause cardiovascular disease that are driven by endocrine hormones.
Yeah, and the body's amazing, and you're absolutely right. Those hormones regulate everything. And when they're not right, I mean, I can tell you, many people with the thyroid issues, it's difficult to control. So,
absolutely.
Yeah, so now with the aldosterone and the hypertension, how do you do that? What is hypertension, first of all? If we could explain it to the listening audience as something that they can wrap their head around. Like I think I mentioned, I'm hypertensive, I'm taking medicine, I'm no longer suffering from hypertension. My blood pressure is fine, but so how would you explain this to someone? Is it something that goes away with a pill?
It's something that is effectively treated by medications in most people, although one of the messages that I wanted to convey to the audience is that if you have been diagnosed with hypertension, by your primary care physician, or perhaps you've even seen a cardiologist or an endocrinologist specialist in the hypertension field, and they're struggling to control your blood pressure, which happens in up to half the patients who are diagnosed with hypertension and are not under control these days. Then there are specialists who are more familiar with some of the newer therapies. We're developing one at Syncor called Baxdrostat, which I'm happy to tell you a little bit about. And the field of hypertension has been a little sleepy for the last 10 years because there were a lot of blood pressure medicines developed in the 80s and 90s, and we thought, and many physicians thought, we had enough. But the latest data from our national epidemiology databases show that about half the people with hypertension are not controlling their blood pressure. So if you are, Jones, congratulations. I'm glad that your doctor or you have found a regimen that works. But there are a lot of people out there for whom the right regimen has not been found and their blood pressure is still not under control. The definition of hypertension has been evolving over the years. It's a little bit like the definition of high cholesterol. It's been going down over the years as we do more studies that show that numbers that previously were thought to be healthy are not quite as healthy as we thought they were, just the way that has happened in cholesterol. So it used to be that the two numbers that we worry about are when you get your blood pressure taken, somebody in the healthcare office, a nurse or a physician, or even the medical technician in the office will put a blood pressure cuff on your arm and they will squeeze it up. And then the first number that they hear through the stethoscope is called the systolic blood pressure, the higher number. And historically, over the last 20 or 30 years, we've considered a systolic blood pressure less than 40 as being a good number. More recent advances in understanding the relationship between heart disease and stroke and kidney disease has suggested that a systolic blood pressure less than 130 would actually be ideal. So that number has evolved to a slightly lower number than it used to be. And on the diastolic side, that's the number, the second number that the healthcare giver hears when they release the pressure in the blood cuff. That's when the sounds stop beating in their stethoscope earpieces. That's called the diastolic blood pressure. And we like to see historically the diastolic blood pressure less than 90. But again, in recent years, we moved that one down a bit to closer to 80. So if your blood pressure is above 140 or over 90, everybody would agree that you have a hypertension. But if you have diabetes or other risk factors, most people would now agree that your blood pressure should be less than 130 over 80.
How's the diagnosis made? Like if I go to CVS and I take my blood pressure, would that be enough to say, oh, I have high blood pressure then? What would the diagnosis, how would it come about?
Well, it's really important to put this into the context of the stresses of a modern life to make sure you don't overdiagnose it, because you go on a day when everything's gone wrong and your stress level is through the roof and you make one measurement and your number's up and it's not reproducibly that high. So most physicians like to measure the blood pressure in somebody over at least 2 or 3 visits to make sure that it's reproducibly high. And you should do it in a setting where you're in a quiet room and you've been seated for a few minutes and you're not racing up the stairs, or you couldn't find a parking spot at your local health care clinic, or if you go to a hospital and you just got into a car accident with somebody bumping them in the parking lot. That's not the time to check your blood pressure, because all of us will have a little bit of a rise there. But if you consistently have a blood pressure above the numbers we just described, and particularly if you measure at home under relaxed conditions and it's high, then that's how we diagnose it. But it's usually done by a physician or a physician assistant in an office on at least 2 or 3 occasions that we're reproducibly measuring the number to be that high.
Are there warning signs? Like, I know it's called the silent killer. Is that truly silent, or are there things that people miss that they could, make an appointment for a checkup, for example? Are there symptoms that are there that we're just not seeing, or is it truly a silent disease?
Well, for most people, there aren't major symptoms that they're going to have until they have a consequence of the hypertension causing some tissue injury, until they have either evidence of a failing kidney or heart failure, or hopefully not, but a stroke or a heart attack. But there are a few things that patients with pretty significant high blood pressure will often experience. Most common is headaches, but headaches occur much more commonly than having them caused by hypertension. So people shouldn't just think, well, because I get headaches, I must have hypertension. But that is a sign sometimes of people with very significant hypertension that they would get headaches. But for the most part, it is pretty well characterized as a silent killer. It really is not something that most people know they have unless they get their blood pressure checked.
So a pretty regular physical is recommended. So you're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Joan Buckley from the nursing department here at Nassau Community College, and today I'm learning about hypertension, otherwise known as high blood pressure. And our guest is Dr. Mason Freeman. He's the Chief Medical Officer of Syncor, which is a clinical stage biopharmaceutical company, and he's also been at Massachusetts General Hospital for over 30 years. So this is his passion. Can you tell us why this became your passion? I mean, your preventative medicine piece, was that an experience that you had and you said, oh my gosh, this could have been avoided had I and my colleagues taken it from this endocrine view and made a change in like just how we communicate, some preventative things that we could teach patients to do?
Yeah, it's been a passion for a long time of mine, and that's because when you take care of people who have any kind of cardiac disease, somebody who's had a heart attack or a stroke, or they are developing renal failure or kidney failure, or they're in heart failure, blood pressure is always close to the number one issue that you would need to deal with. So as a clinician taking care of patients with those cardiovascular problems and trying to prevent a new cardiovascular problem or a worsening of their cardiovascular problem, blood pressure management is fundamental to providing optimum care. But I had a little sojourn. I got interested, I ran an NIH-funded research lab for 30 years at MGH, as you mentioned, and I took a leave of absence back in 2005, and I went across the river in Boston over to Cambridge from Boston, and I worked for a large pharmaceutical company for 2 years on a leave, learning how to make new medicines. And one of the programs that I began to work on when I went to Novartis was an aldosterone-lowering drug that was intended to control hypertension. So I became even more immersed in the hypertension field, dealing with all of the best thought leaders in the hypertension field about what was causing hypertension. And aldosterone became clearly the hormone that got most attention at Novartis and among many of the hypertension specialists. And so it's something I began to study. And we made a drug, we put it into human beings back in 2006. And the problem with the medication was that it blocked the enzyme that's responsible for your making aldosterone in your adrenal gland. But unfortunately, it wasn't specific enough, and it also blocked the production of another hormone called cortisol. And it's not safe to block cortisol. So that program was curtailed. Eventually, that drug became useful for an endocrine disorder called Cushing's, where you overproduce aldosterone and cortisol. So it was very useful medicine, but it wasn't a good medicine for people with just hypertension. And so about 3 years ago, the Syncor company had just been founded, and they contacted me because they knew I'd had this experience working on a drug that had blocked aldosterone synthesis. They said they had one, and would I be interested in helping them? And I began as an advisor, and then last August they said, well, we'd really like you to run the entire development program. Would you take a leave from Harvard Medical School and come help us? And because I really believed passionately in this particular pathway as a way to be a very, very effective way to treat hypertension, I took the leave from Harvard Medical School, and that's how I ended up at Syncor.
So where have you gone from the, when I hear the hormones, I always say, natural kind of, but if you're blocking a natural hormone, so it gets a little difficult, right? So I understand why that one may have caused trouble in some respect, but how do you see the change going to be now with the hypertensive medications? Like, can you share with us what you're looking at now?
Yeah, so the name of our hypertensive medicine generic name is Baxdrostat. It doesn't have a brand name yet because it's still experimental. We're still doing the clinical trials that would be required for the FDA to approve the drug. So everybody who's listening should know they can't go out and ask their doctor to prescribe it today. It's not available. We're in the clinical development stage. But what Baxdrostat does is it inhibits or blocks the protein in the adrenal gland that converts the steroid hormone that is a precursor or beginning molecule that will become aldosterone. It blocks the adrenal gland's ability to synthesize aldosterone. Now, it doesn't block it 100%. The information that we have from human studies, it blocks it about 70%. But unlike that medicine that I tried to develop at Novartis 15 years ago, the studies we've done show it doesn't block cortisol. So the new chemistry has made it just more specific. And so that safety concern, we think, has completely been eliminated by this new medicine. So what it does is it blocks the adrenal gland's production of aldosterone by about 70%, perhaps a little bit more in some people. And what that does is aldosterone tells your kidney, hold on to salt, hold on to water. If you lower the aldosterone level, then the kidney can eliminate more salt and more water, and your blood pressure falls. So you're using the physiology, the normal biology of aldosterone, but by lowering it, you're asking aldosterone, don't do as much as you were doing. It's too much. My blood pressure's high. I need to get rid of some of this salt and fluid, and with that, the blood pressure will fall. And so that's what we're demonstrating in our clinical trials right now. We're about to report out our first study result in the early part of the second half of this year, probably sometime late summer. And with that, we will have evidence about how well we're lowering it. And we're treating the hardest people to treat right now in the hypertension world. That is, we're treating people that have something called resistant hypertension, which means they're taking at least 3 blood pressure medicines, one of which is a diuretic, so a typical thiazide diuretic that many patients may be taking with hypertension. But they're on at least 3. Many of them are on 4 or 5, and they still don't have their blood pressure under control by the numbers that I quoted to you earlier. Their systolic blood pressures on average in our trial are almost 150, and so they need their blood pressure lowered by about 20 points in order to achieve the goals that I was mentioning earlier, trying to get down to a systolic blood pressure of 130 or less. So that's the study that we're doing right now, and we'll know what the results are at later this year.
I think that's very exciting. How do you, I know this is it's very chemical, but it's not really. It's a little physiology. And I think you explained it very simply. To be honest, to anyone who wasn't in the field, you talked about sodium, salt. Everybody knows salt. Everybody knows, that they have too much salt. They're going to have water and, that kind of thing. So everybody kind of knows that. So you did a great job, I think, speaking to the community on it. But when someone is having trouble with hypertension, on a basis before these, hopefully a newer drug is, right? You said 3 or more they can enter. That's a lot of medication. So what kind of side effects do people that are on that kind of medication, what kind of side effects do they have to know to watch for?
Give you a quick primer on the medications that are used today and to treat hypertension. There are 3 classes of medicine that cover about 75-80% of the prescriptions for hypertension in the United States, at least. And those are drugs in what are called the ACE or ARB class. So those are drugs, the ACE inhibitors end in the word pril. So there are things like lisinopril, captopril, anything ends in PRIL as a generic name is an ACE inhibitor. And then the angiotensin receptor blockers or ARBs are drugs that end in tan, so like valsartan or losartan. Those are all generic names. Those aren't brand names. Those are generic names, and they're all generic medicines. So they're inexpensive for the most part, and they're widely utilized. They're the most widely prescribed starting medicine. ACEs or ARBs, your physician may prefer one or the other, but they're not usually used together, so you get on an ACE or an ARB. Then the second group is typically a diuretic, and people are very familiar with those. Those are thiazide diuretics like hydrochlorothiazide or chlorthalidone. And then the third class of medications are drugs that are called calcium channel blockers, and amlodipine would be an example of that. But there are many of these in the generic class. And so when we talk about the patients that we're seeing who have resistant hypertension, they're basically on one of each of those. They're on an ACE or an ARB, they're on a thiazide diuretic, and they're also taking something like amlodipine or a calcium channel blocker. And despite those 3 medications, they still have a blood pressure that's too high. And so we're testing our medicine on top of those medicines to show that we can bring the blood pressure down. And then the issue will be for the doctors and for the healthcare system and payers to say, well, if our medicine works really well, maybe you would want to introduce it earlier than getting to your third or fourth medicine. And that's something that we'll have to demonstrate there's value in the clinical trials, and those are yet to be completed. So I don't know that it will be useful earlier, but we hope that we will show that it has a lot of effectiveness no matter what your background blood pressure medicines are. But that's the work that we're doing now as we try to develop this new medication.
Wow. You're listening to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. My name is Joan Buckley from the Nursing Department here at Nassau Community College. And today you're learning about hypertension, otherwise known as high blood pressure. And our guest is Dr. Mason Freeman, Chief Medical Officer of Syncor, and also affiliated forever, 30 years at Massachusetts General Hospital. So, Dr. Mason Freeman, I just wanted to know, what is the connection if someone has hypertension? I always tell students that you have to look at everything that is involved in a person. So with hypertension, frequently people have diabetes. So what's the connection between hypertension and diabetes? Is there something that it would be good if our listening audience kind of understood the connection and the importance of treating hypertension?
Yeah, there are a number of connections that are involve things in people's lives that they can either associate with a risk for hypertension or are things they are doing that they might be able to improve that would reduce their blood pressure and reduce their risk. So one of the very direct connections between diabetes and hypertension is the prevalence of being overweight or obese. Being obese or overweight is highly correlated with hypertension. And that, of course, is also highly correlated with the risk for developing type 2 diabetes. But in addition, people with diabetes, particularly long-term diabetes, tend to develop chronic kidney disease. And that actually is a risk factor for developing hypertension. And it also hypertension makes their kidney disease worse. So it's a kind of vicious cycle that if you have diabetes and you're beginning to cause some damage to your kidney, particularly if your blood sugars are not well controlled, then you can begin to develop hypertension. You're overweight, and that's also contributing to hypertension. And now the hypertension begins to also damage your kidneys independently. So these two things, or three things, diabetes, obesity, and kidney disease, are very, very commonly associated in the population. And it's very important for people to pay attention to that because long-term diabetes is a major risk factor of your actually ending up in end-stage renal failure or kidney disease and requiring dialysis. And it's a major cause of mortality in people with diabetes. So controlling blood pressure in a diabetic is incredibly important.
How many people have hypertension? I'm sure you know.
I do, and it's a frighteningly high number. In the United States, it's estimated that about 115 million adult Americans have it. So that's almost half of the adult American population. It's huge. It's the single most common cardiovascular risk factor is hypertension by a wide margin. And only about half of the people that have it have their blood pressure controlled. Now, sometimes that's because they're not getting good medical care. They're either not seeking it, or where they're getting it, they're not being aggressively treated. But it's estimated that about 12 million Americans have something that's called resistant hypertension, where they need much more therapy. And of those, 25 or 30% have a particular condition where their adrenal gland is overproducing this hormone aldosterone. And they are very difficult to treat. And unfortunately, they are rarely diagnosed. The people that diagnose this condition, which is called primary hyper, meaning excess aldosteronism, are almost always diagnosed by endocrinologists, people in my specialty. And unfortunately, except if you're at a very sophisticated academic medical center, there aren't that many endocrinologists who specialize in the diagnosis of this condition, and therefore a lot of patients who have this very, very severe form of hypertension don't get diagnosed, and their primary care doctor, or even sometimes their cardiologist or kidney doctor who may be taking care of their blood pressure, is struggling to bring their blood pressure under control. And these individuals end up having very high risks of stroke, heart attack, and renal failure and heart failure. So it's really important they get to the right place and get a diagnosis, because there's quite effective therapy if they're diagnosed.
Now, what is the one thing, if you had to leave one thought with our listening audience, what is the one thing you would want to leave us with when it comes to talking about hypertension?
It's, first of all, make sure you've been tested, that your blood pressure has been measured so that you know whether you have it or not. And then do the lifestyle things that can make it better, which is cut the salt out of your diet, lose weight if you can, exercise if you can. If you're smoking, it would be best to stop. Those are all the things you can do on lifestyle. But once you've done those or done the best job that you can, if your blood pressure is elevated, go seek treatment initially through your general practitioner and primary care physician. But if they can't bring your blood pressure under control, you need to see specialty care so that you can get the most effective therapy that we have today to control your blood pressure.
You know, I'm learning a lot from you today. I just want to tell you. And where can someone that's listening to you right now, or whenever they hear your story, where can they reach you? Is there any information, like a website?
Yeah, well, first of all, if they want to reach me, there's Syncor.com is the website of the company that I'm working on, and my contact information is there, and you can reach me through there. There are good public resources on hypertension. The American Heart Association has a lot of information about hypertension and how to seek care and lifestyle treatment. And our Syncor website will tell you about our clinical trials. If you have hypertension and would be a candidate for being in our trials, we'd love to involve you in helping us develop this new medicine. And it also, there's a good deal of background information about aldosterone and what our drug would do that might be of interest to some of your listeners. There's a lot of information on the website, most of it probably more directed at medical professionals than the general public, but at least you can see what trials we're doing and how you could contact us if your blood pressure has not been easily controlled, because you would be somebody we'd really love to recruit into our studies so we can see if we can help you get your blood pressure down.
You know, you're absolutely right. The website is excellent, and I do think it does speak to the audience, so I think that there are a lot of things that they could learn from that. Thank you for being here, Dr. Mason Freeman, Chief Medical Officer of Syncor Clinical Stage Biopharmaceutical Company. He's also been affiliated for over 30 years with Massachusetts General Hospital, for more than 30 years. I have learned a lot from you today. So I just want to hope you stay safe, continue to stay healthy, and continue to do the great work that you've been doing. And this is Joan Buckley. Do you have anything to say, Dr. Freeman?
Thank you, Joan, so much for giving me the opportunity to speak with you. And hopefully your audience learned a little bit about hypertension. I hope that somebody out there maybe will go get some care that they should get that they're not getting now.
That's terrific. So thank you very much. This is Joan Buckley again from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.